I think we have to begin at the beginning, which is to understand that hairs do not grow as single items, but as follicular units. And there are discrete clusters of 1 to 4 hairs. And if we understand that, we begin to understand how we can approach this surgically. We're going to really focus not on all the medical management and other things, but just on technique today. There's really, if you look at the evolution, we went from plugs to mugs to fugs. And what does that mean? Basically, plugs were huge 4-millimeter round grafts that were removed in a punch fashion from the donor site. We moved to smaller grafts, which are either called quarter grafts or half grafts. They cut them to smaller pieces. Then we started to understand that hairs grew in follicular units. So since the 1990s, we've done purely follicular unit grafting. Well, how is a plug separate from a mug? A plug was large round grafts that were angled poorly, that were placed with a lot of bare space between it, so you could see these compressed round grafts of 16 to 20 hairs. MUGs, or multi-unit grafts, are basically 2 to 3 to 4 follicular units that are placed in a much tighter orientation behind rows and rows and rows of follicular unit grafts in select patients who would benefit from this. And I think if you maintain the natural spacing of hair and don't compress the grafts and place them behind multiple rows of follicular unit grafts, you can achieve a good density in a single session. So I'm going to go through sort of the mechanics of walking you through a day in the operating room. I like to use a level 2 conscious sedation with a fentanyl Versed mix so that they feel very comfortable. And you can do this using a vibration device and a very slow buffered solution to minimize the discomfort. I find this really helps me achieve patient comfort very well. Obviously, this has got to be in a monitored setting. After the hairline is designed, the occiput is shaped, and I really believe in harvesting very thin, long strips that go into the temple region, obviously not far enough that you're going to have some retrograde hair loss or some drop of your lateral humps over here to create exposure, and that's something that requires a skill set of understanding how to do that. As you know, with any kind of removal, the thinner an area, like even if you do an excision, and there's less tension on it. And in this case, you can't undermine because you're going to have issues with destroying the natural donor hair. The ring block is placed inferior in a circumferential fashion using standard lidocaine. And then this is a real key is, oh, not yet. Donor tumescence, but recipient tumescence, I just prepare the bed with a little Kenalog and a little dilute Kenalog and a little bit of epinephrine. I'll be happy to send this to you if you want the actual mechanics of this. And then I work with the donor area, and I don't do a lot of tumescence into the face when I'm doing fat transfer because I think there's some architectural changes when you put a lot of tumescence in. But when I'm doing a facelift and I'm doing a hair transplant, there's a lot of tumescence, and there's a ton of tumescence when I do hair transplant. I like the analogy of understanding a ship on over corals. When the ship is at high tide, it won't scrape the corals. When it's at low tide it'll scrape the corals. What does that mean? Your blade is the ship, and the coral is all the nerve and blood supply. And so I really believe in doing tumescence well and taut and blanched and flat even before I harvest. It actually takes me about 15 to 20 minutes to fully tumesce the area until it's flat, blanched, and ready to harvest. That minimizes the bleeding. It minimizes transection of deep nerve in terms of postoperative discomfort. And that also, the harder your blood supply, the better your graft take as well. So I think it's very, very, very important to do good tumescence in this area before you start the harvest. This is just an illustration that's in a book that I finished. I don't know when that's going to be published, but it's about understanding different angles, and so that you're getting really visual feedback for transection, and really understanding you got to take this slowly. A lot of times people take a lot of pride in the recipient area, but they just slam through the donor site in minutes, and you have to take time with a good harvest. Then I go back and I put a marquine block in, same place where my lidocaine block was, which is inferior to all the areas I'm working. It's important that also, if you know the anatomy, that even if you're working in the crown, that you do an anterior block of some kind, because the supratrochlear nerves and the supraorbital nerves go all the way back and feed a huge percentage of your crown region. The recipient site is a little different in terms of the strategy for tumescence, in the sense that this has a little bit more Kenalog in this area because you don't want the edema to settle on your forehead, and it's a sequential tumescence. So a lot of times when you're doing site creation in the recipient sites, if you don't put the recipient tumescence in, you're just working on bare bone, and you're tapping through and destroying all the local vascularity. So that tumescence in this area is very important, because for me it takes me about an hour and a half to make my recipient recipient sites, I do a sequential area. So I'll tumesce the area that I'm working on a certain number of sites, then I'll tumesce the next area in a sequential fashion, versus on donor, you want maximal tumescence before your blades go through. Really important is the patient positioning. When you're making these sites, one thing I'll say is I talk to a lot of plastic surgeons, facial plastic surgeons, who work with recipient site creation, and they just sort of think you just stick a site in there and it's going to grow hair in a certain way. Unless you understand how hairs naturally grow in a head, you're going to do a disservice to the patient. And hairs grow differently in the hairline for a male and a female versus an African American, an Asian, a Caucasian. It grows differently at the point where it's coming down into the lateral hump. Unless we understand how hair naturally grows, we're doing the wrong thing. And some of the big mistakes I see when people are designing sites for recipient sites is the hair angles are way too high. You can see insertion points, and if you think about it, if the angles of the recipient sites are like this, you're going to get no density because all the hairs are straight up. There's no shadow effect that's created over the bald scalp. And if you really look carefully at male hairlines, the hairs are angled low and straight. The other mistake I see when people are making recipient sites in the mid scalp to the hairline is everything is splayed wide open like a book, because your natural tendency for your hand is to angle it to match the curvature of the scalp. You do that, you can't comb your hair. It's all a big book-leaved open area and there's no density. So all the sites are very low angled and anteriorly placed. The way that you do that is you have the patient in a fully supine recumbent position, so your hand naturally follows an angulation that's very low. And you actually, there's almost no angle that's too low in the frontal hairline, but there's almost always too high a pattern. So really, before you start transplanting, understand how hair grows before you make your sites, because otherwise you're making crazy sites that don't mimic reality. And we'll show some of that work in a moment. So again, understand how hair grows naturally. It grows differently in the hairline, it grows differently in the mid-scalp and the lateral hump, and it grows differently at the vertex transition point, which is the back side of the, where it goes to the crown, and then it grows differently in the crown. I like a different model of understanding hair. I use a model of a box. And if you think of a box, our hairline, our top of the scalp is our hairline mid-scalp. The sides here are the lateral hump, which grows very differently. Our back is the crown, so you have to visualize it in that way. I'm giving you sort of a very bird's eye view of this, but the idea is just, my goal of anything in a short 30-minute lecture on hair is don't start it until you really understand what you're doing, and don't just stick graphs up there. How do I create this? If I'm doing the multi-unit grafts, which are the stronger, larger grafts, I build the hairline forward. A lot of temptation is to start with the hairline and move it back, but that's going to create too straight a hairline, one. And two is that when you're using slightly larger grafts, it's much easier to interlock the smaller grafts into the large grafts than the other way around. And you want to be able to visualize you don't have empty spaces. Otherwise, you can look grafty. So I first build up the front part of my multi-unit grafts, and I go all the way back and fill in that space. These are what are known as sagittal sites, which means they're angled in a way that hair naturally grows in this direction. Some people are proponents of making sites what are called lateral slit or perpendicular sites in this direction. I believe that there are many ways to skin a cat. It just depends on where your comfort zone is and your aesthetic values. And you can see that as I build the hairline forward, that I'm much more likely to create a very tight interlocking pattern from my multi-unit grafts into my follicular unit grafts by going larger to smaller. And then as I build the hairline forward, I don't create a rigidly straight line. A hairline is more of a zone of transition. And if it's a female, I'm a little bit tighter. If I'm dealing with an older male with a significant degree of recession, I'll be working with more of a staggered hairline. But otherwise, if I'm working with someone in the 30s, 40s or so, I'm making a relatively small micro change to the hairline, because you don't want these big waves. We're talking about 2 millimeters of undulation. This is the vertex or crown, and if you look at it, if you look carefully, I don't know if you can see the sites, they're perfectly angled to create a natural pattern for a crown. I'm not going to go into a lot of the details of understanding how to design a crown, but I just want, again, to use this photograph not to teach you how to do hair transplantation in a short time period, but teach you that if you're going to engage in the art of hair restoration, treat it seriously, understand how hair grows. Don't treat it like a stepchild of plastic surgery, because that's oftentimes what happens, and then you get devastatingly bad results. And I really look at this way. You know, you really have only a certain amount of donor hair in the back of your head. You go abuse that donor hair, especially in a young gentleman that may not even benefit from it. We talked about long-term consequence of fat grafting. We have to also understand a long-term consequence of hair. You got a 20-year-old that's losing hair and you want a low hairline, you're going to create this weird looking thing when they run out of donor hair in 20 years. So be very careful. This is to show you that the angulations for a female are radically different from a male. And I find a lot of people that do hair in women, 30% of my transplants are actually in women, because I cater to women, is that it's actually different. It's a cowlick. There's ideas of a little bit of lateral mounds that come projecting to the sides. The way that the temple angles are actually completely different. They're closed down and they're almost a rounded shape for an ideal female hairline. The sights that I told you about in the male that are low forward angled are the exact opposite in a woman. They're almost angled back and up to the side like a cowlick, and I'll actually design that rotating cowlick in the female. So again, it's not rocket science, but it's dedication. It's dedication to excellence in every level, and understanding all these details makes a huge change. This is an Asian. You can see how you create very fine FUGs in the front end. You cannot see my MUGs on the back side. This is 2 sessions here where with the female with a little hair coloring, and you can see that we've closed the frontal temporal angle down significantly and angled the central areas in a swirling pattern to create that cowlick. This is an example of some corrective work, and you can see there's almost this, I hate to say, pubic quality to the hair on the left, and the reason is due to the graft placers and dissection. A lot of times as surgeons we think, oh my goodness, we're some kind of deity because we do all from a rhinoplasty. Is that in the world of hair, the surgeon is only 30% of the equation. There's a good saying that if you give me the most experienced technician team and the worst surgeon, I'll probably get you a better result than a good surgeon and a bad technician team. And this is a great example of compression of the grafts, almost some degree of pitting, but not too much. And of course the hairline is badly designed and the angles are badly done, so it's a bad outcome all the way around. This is a single session correction, re-angulating the grafts downward and creating a much more density in one round. This is, again, technical error both on the part of the surgeon as well as the technician team. What are the errors? One is the fact the angles are too up. The hairline is way too straight. There is no temporal reconstruction, so it looks almost like a toupee because it's extending out beyond where the temporal area is. And if you understand that a proper frame to the hair must compensate for both. The reason that when we're looking at a toupee that looks fake is because the hairline is so far jutted forward that it doesn't match where the temporal recession is. And it's not just the fact that the ways of the angles are off, because nowadays with hair systems that are woven, they're very natural in appearance. Oftentimes the best thing for those people that wear a system is just to rebuild the temples, and you get balance. And obviously you can see as well some pitting. There's actually these little clumps, and the trick is when the technician is placing the grafts, they need to be placed about a little less than a millimeter above the surface of the surrounding skin so that they recess back into it. You place them flush or slightly low, you're going to get this pitting effect. Again, a natural hairline, as you see. This is, again, terrible angulations. This is probably mostly the part of the surgeon's fault. Bad hairline design, angles that are straight up. You can see the insertion points of the grafts. And this is softening the hairline, bringing the angles significantly lower, using much smaller grafts, and bringing it back into a much more natural state. This is just a 1-session transplant that encompasses everything but the crown. Conclusions is that if you're going to do MUGs, to do it with care and to do it with after at least watching some surgeons doing it and using care and understanding, the good selection of a good patient candidate for this. And I think that MUGs add another paintbrush, if you will. You have more things that artistically you can use to create a good result. As a small promotion for a course I'm doing in November in St. Louis, what's great about this is it's all hands-on, because a lot of times when I first started making sites, I didn't know when my sites were bad, and until someone was able to watch me. And so I'm going to actually watch you make your sites. And finally, it's a merger of technicians and surgeons. So very proud of this course coming up in November. Thank you very much for your time.